Welcome to Medico Link, and I am Dr. Prashant Gupta, and today we'll be talking about hemoglobin disorders and mainly the sickle cell anemia. So let's start. So hemoglobinopathy is hemoglobin disorder disease, and this hemoglobin disorder can be either qualitative or quantitative. Qualitative hemoglobinopathy refers to alteration of amino acid sequence in globin chain, also known as structural hemoglobinopathy. For example, sickle cell anemia. And in case of quantitative hemoglobinopathy, refers to a particular globin chain that is synthesized less than the other. For example, alpha thalassemia and beta thalassemia. So talking about qualitative hemoglobinopathy refers to alteration of amino acid sequence in globin chain, which is also known as structural hemoglobinopathy. This is seen in sickle cell anemia. In sickle cell anemia, the most common genetic change is point mutation. So what kind of point mutation? It is missense type of point mutation. So it is missense type of point mutation where glutamic acid is replaced by valine in the 6th position of beta chain. So the glutamic acid, it is replaced by valine in the 6th position. So glutamic acid is soluble, negatively charged and polar amino acid. So glutamic acid is soluble, negatively charged, and it is a polar amino acid, whereas valine is insoluble, neutral, and it is non-polar amino acid. So there is a change in solubility. Now coming to quantitative hemoglobinopathy. Quantitative hemoglobinopathy refers to a particular globin chain that is synthesized less than the other. For example, alpha thalassemia and beta thalassemia. In alpha thalassemia, there is decrease in alpha chain, whereas in beta thalassemia, there is decrease in beta chain. So alpha thalassemia is due to deletion in the globin chain, whereas beta thalassemia is due to point mutation. So what kind of point mutation? It is because of nonsense or stop codon type of point mutation. It is nonsense or stop codon type of point mutation which encodes UAA, UAG and UGA. Now we'll talk about sickle cell anemia in detail. So sickle cell anemia. Sickle cell anemia is a autosomal recessive disorder, and it is more commonly seen in pediatric patients of Africo-American origin. And hemoglobin in homozygous state is HBSS, that is sickle cell disease, and hemoglobin in heterozygous state is HBSA. It is HBSA, and it is a sickle cell carrier or a trait. And the most common abnormal hemoglobin variant is HBS. Now we will discuss on pathophysiology of sickle cell anemia. In sickle cell anemia, due to point mutation. So what kind of point mutation? It is partially acceptable missense type of point mutation. It is partially acceptable missense type of point mutation. So looking at the DNA level, this CTC is changed to CAC, that is due to mutation this thymine is replaced by adenine. And in mRNA level, this GAG is changed to GUG, that is due to point mutation this adenine is replaced by uracil. This GAG is encoding the glutamate. GAG encodes for amino acid glutamate, whereas GUG encodes for amino acid valine on the 6th position of beta chain. So what happens is the glutamic acid is replaced by valine. Glutamate is HBA and valine is HBS. This glutamate is a polar amino acid which is water soluble and it is negatively charged. So glutamate is negatively charged water soluble polar amino acid, whereas valine is non-polar amino acid, water insoluble, and it is neutral. So valine is neutral, water insoluble, and non-polar amino acid. Therefore there is a change in solubility, that is solubility gets altered. Now this HbS will have sticky sites. So this HbS, that is sickle cell hemoglobin, will have sticky site on their surface. So HbS will have sticky sites present in both oxygenated and deoxygenated state. During hypoxia, this complementary site will be expressed. So when there is lack of oxygen, this complementary site will be expressed on HbS, and this complementary site will bind to sticky sites of another HbS. This HbS having complementary site will bind to another HbS having sticky sites. So they will form a long chain resulting in polymerization of HbS. Now this will convert hemoglobin into needle-like hemoglobin crystal, that is RBC will change to sickle shaped, also known as drepanocyte. This polymerization of HbS will also cause increased expression of adhesion molecule of sickle cell, resulting in thrombus. Because of adhesion of molecules of HbS in sickle cell anemia will result in the formation of thrombus. This thrombus will obstruct the blood flow to distant organ. So blood flow to the distant organ will be obstructed, which will result in ischemia. This will further result in infarction and fibrosis, and this process is vaso-occlusive crisis. So this will result in vaso-occlusive crisis. Now, what are the factors affecting sickling? The most important factor is HbS concentration. The most important factor is HbS concentration more than hypoxia, which will result in sickling. In case of sickle cell trait, it is HbSA. HbA is 60%, whereas HbS is 40%. So this S will contribute to 40% and this A will contribute to 60% of HbSA, sickle cell carrier. So there will be no sickling because this HbA already has a receptor for sticky site, and this will inhibit the polymerization of HbS. So HbA has no sticky site. HbA has no sticky site. So you see here, this HbS has a sticky site, whereas HbA has no sticky site. So this will inhibit the polymerization of HbS. As HbA has no sticky site and HbA already has a receptor for sticky site of HbS, it will cause inhibition of polymerization of HbS. Therefore there will be no sickling. Now other hemoglobins like HbA, HbF and HbC. So what are their effect on sickling? As we have already said, HbA inhibits polymerization of HbS. Similarly, this adult hemoglobin and fetal hemoglobin will both cause inhibition of polymerization of HbS. This will cause decreased sickling. So in fetal hemoglobin there will be no sickling up to 6 to 9 months, as HbF persists for up to 6 months. Also, anemia, jaundice and other symptoms in fetal hemoglobin occurs only after 6 to 9 months, because fetal hemoglobin reaches the adult hemoglobin only by 6 to 9 months, before which they are asymptomatic. In case of HBC, that is HBSC, this HBC will remove sodium and water from the cell. This HBC will remove sodium and water from the cell. This will cause increase in concentration of HBS. So there will be increase in HBS concentration, thus resulting in increased sickling. So in HBC there will be increased sickling, whereas in HbA and HbF there will be no sickling. This HBC is characterized by increased incidence of proliferative retinopathy and bone marrow infarction. So this is a characteristic feature of HBC, that is proliferative retinopathy and bone infarction. Now coming to mean cell hemoglobin concentration, because of dehydration there will be increased mean cell hemoglobin concentration. So when there is increase in hemoglobin concentration, this will cause increase in HBS level. So this will cause increase in concentration of HBS, which will result in increased sickling. In case of acidic environment or in case of acidosis where there is decreased pH, this decreased pH will have decreased affinity for oxygen. So when there is decreased oxygen, there will be more carbon dioxide, which will form carbonic acid, which will degrade into hydrogen and bicarbonate. So when there is decreased affinity for oxygen, that is, it is in hypoxic state. So when there is hypoxia, this will result in increased sickling. Now when sickle cell anemia presents with thalassemia, there will be decrease in hemoglobin S. So there will be decrease in HbS. As in thalassemia, there is decrease in chain synthesis. There will be decrease in chain synthesis. So this will cause decrease in sickling. So in summary, the factors affecting sicklings are HbS concentration. So increase in HbS concentration will cause increased sickling. In sickle cell trait, there will be decreased sickling. In case of fetal hemoglobin and adult hemoglobin, there will be decreased sickling. In case of HBC, there will be increased sickling. In MCHC, due to dehydration, there will be increased sickling. In acidic or low pH, there will be increased sickling. And in case of sickle cell anemia with thalassemia, there will be decreased sickling. Now, what are the clinical features of sickle cell anemia? The clinical feature of sickle cell anemia includes vaso-occlusive disease, aplastic crisis, and sequestration crisis. So, among these, vaso-occlusive crisis is most common clinical feature. In vaso-occlusive crisis, as we have already discussed, hypoxia will cause increased expression of adhesion molecule, which will result in thrombosis. This will cause ischemia, infarction, and fibrosis, which will result in other symptoms like hand-foot syndrome, acute chest syndrome, fish-mouth vertebra, and autosplenectomy. So hand-foot syndrome is most commonly seen in pediatric age group, and they will present with painful extremities, that is dactylitis. In extremities, as we know, there are end arteries. This will result in ischemia of hand and foot. So they will present with inflammation, pain, and edema of the extremities. So this is known as dactylitis. In acute chest syndrome, due to ischemia and infarction of the lung tissue, there will be dyspnea and chest pain. So this chest pain is not of angina character, because in angina there is radiation of pain to dermatomal areas. They will also present with fish mouth vertebra. So this fish mouth vertebra is a biconcave appearance of vertebra. So this is a biconcave appearance of vertebra, which will look like a vertebra of a fish. They may also present with autosplenectomy. So due to thrombi, ischemia will develop, which will lead to infarction, and fibrous band will replace the spleen. So the spleen is the graveyard of RBC. As we know, the spleen is graveyard of RBC. Even though there is no spleen, bone marrow will continue to produce RBC. So it will send feedback signal to the bone marrow. This will result in dyserythropoiesis. Some RBC will escape from the bone marrow and come to the peripheral blood along with remnant of nucleus. So this is the Howell-Jolly bodies. This Howell-Jolly bodies is composed of DNA remnants. These Howell-Jolly bodies are also seen in case of megaloblastic anemia, sickle cell anemia, hemolytic anemia, and splenectomy, that is surgical removal of spleen. Now we'll talk about another crisis, that is aplastic crisis. This aplastic crisis is caused by parvovirus B19. This parvovirus B19, it is transient and it lasts for 5 to 7 days. This parvovirus mainly cause damage to erythroid progenitor cells, granulocyte precursors, and platelet precursors. That is, all the stem cells are affected. And the most common stem cell that is affected is erythroid progenitor cells. So parvovirus B19 will cause more damage to erythroid progenitor cells. This will result in pancytopenia or aplastic crisis. Now coming to sequestration crisis, this is seen in pediatric patient, and this sequestration crisis is most dangerous and life-threatening crisis, as large amount of RBC is suddenly dumped within the spleen. This will result in painful and acute splenomegaly with hypovolemic shock. So the patient will die within 48 hours. So the treatment is blood transfusion. So the treatment is early blood transfusion within 48 hours. So this is considered as medical emergency. This sickle cell anemia may also present with osteomyelitis. And the most common organism causing osteomyelitis is Salmonella. Whereas in other osteomyelitis, the most common organism will be Staphylococcus. Whereas in sickle cell anemia, the most common organism is Salmonella. Now we'll talk about other clinical features. So sickle cell anemia may also present with crew haircut or hair on end appearance. So on X-ray of skull, there is new bone formation on the outer table of the bone. So it produces perpendicular radiation resembling a crew cut or hair on end appearance. So this is also seen in case of hereditary spherocytosis, iron deficiency anemia, neuroblastoma, enzyme deficiency disorder like G6PD deficiency, sickle cell anemia, and thalassemia major. So there is a mnemonic high nest, HINEST, high nest, where H is hereditary spherocytosis, I is iron deficiency anemia, N is neuroblastoma, E is enzyme deficiency like G6PD deficiency, and S for sickle cell anemia, and T for thalassemia major. Now what is gamma Gandhi bodies? Gamma Gandhi bodies is due to sequestration crisis. So in gamma Gandhi bodies, this will show sign of congestive splenomegaly. Why congestive splenomegaly? It is because large amount of RBC is dumped within the spleen. And these gamma Gandhi bodies are composed of iron, calcium, and fibrous tissues of spleen. Iron, calcium, and fibrous tissue of spleen. This iron is stained by pulse Prussian blue, and they will show bluish appearance. And the iron will show bluish appearance, whereas calcium is stained by von Kosa stain, which will appear black in color. Now, these gamma antibodies are also seen in case of sickle cell anemia, liver cirrhosis, and CML. Now, coming to the diagnosis, we will look into peripheral blood smear. This peripheral blood smear will show sickle cell, target cells, and Howell-Jolly bodies. So this peripheral blood smear will show sickle cell, target cells, and Howell-Jolly bodies. Now coming to the screening test. So screening is done by sodium metabisulfite and sodium thionite. And the confirmatory test for sickle cell anemia is hemoglobin electrophoresis. And investigation of choice for any hemoglobinopathy is HPCL, that is high performance liquid chromatography. So it is the best confirmatory test. So the investigation of choice for any hemoglobinopathy is HPCL, that is high performance liquid chromatography. Now coming to hemoglobin electrophoresis, so there will be anode on one side and there will be cathode on the other side. Anode is positively charged and cathode is negatively charged. As we know, glutamic acid, that is HbA, is negatively charged, and valine, that is HbS, is neutral. So the anode, which is positively charged, will attract negative particles. So when HbA, HbS and HbSA, that is sickle cell anemia and sickle cell trait, is introduced on the cathode side, as HbA is negatively charged, it will go further away from the cathode and towards the anode. Whereas HbS, that is sickle cell anemia, being neutral, they are not much attracted to the anode. And HbSA, it has both A and S. So HbA, that is the glutamate, will move farther away from the cathode, whereas S will lag behind. So HbS will be slow, S for slow, and A for ahead. So HbA will be ahead and HbS will be slow, so they will be lagging behind. And HbS and HbS will have single band, so there is a single band, and HbSA will have double band, that is they have two bands of HbS and HbA. So this was all for today. I guess you have understood the topic. Thank you.